Hello everyone. Okay, so welcome to the cardiovascular lecture. I have on my computer screen my cardiovascular PowerPoint in front of me, so I will let you know when I progress on to the next slide, but I definitely want to encourage you to either print it out and have it available with enough paper to kind of fill in the blanks as I'm talking, or have your computer in front of you where you can see as I'm talking, because I'm going to write on my board, and then just kind of type away. Just for your own learning, there is a huge amount of research that shows that if you actively write out your notes instead of typing, that there's better retention. So it's kind of an old school way of thinking, but it's actually a good way of thinking. So when you're typing, same font, all the same color, and you don't have any outliers to help stand things out, it can make it really tough to kind of retain that in your brain. And also the act of you typing on an A is no different than typing it on an M because of this manual, going through the actions of doing penmanship. So there is a big amount of research that shows that you actively engaging in writing has a better retention. So I definitely, I'm throwing it out there, and I believe in it. So we'll see. Let me know if you convert from typing away to writing it out this semester, and tell me how it works. So the first slide is cardiovascular assessment. And all of our medical kind of diagnoses, I like to start off with the system and talking about the assessment. I know that you guys have had this a bunch of times throughout your career as a nursing student, but in advanced med-surg land, it is super important that we are all on the same wavelength. Why is that important? It guides what your assessment is for our critical patients. So let's talk about cardiovascular assessment. And please, as you're watching this, if you have any suggestions on how you want me to, improve upon how you can read stuff, just let me know. If you want me to write bigger, I forgot to bring home my colors from my office on campus. So the next time you see a lecture, you'll probably see me writing more in black, in a really big black erasable marker. But I have my girls' ones, so I have purple, kind of a magenta color, and then some blues right now. But definitely let me know if I can change anything, so that way you can see what I'm writing. So cardiovascular assessment, we have 7 functions to why we're doing a cardiovascular assessment. So those are the things that I really want to spend time right now talking about. And the first one is delivering oxygen and nutrients to wherever your cardiovascular system is pumping out the blood to. And I'm not talking necessarily about transport. I'm talking about delivering. I have a cardiac output and a strong, heartbeat where I have a pumping going on where my blood is going to get delivered, move to my right big toe. The intent is to, through each pump and an open arterial system, move the blood to get to the end result of my right big toe, right? And the entire purpose of getting it to my right big toe is to deliver oxygen and nutrients to my right big toe because I want it to work, right? So how do we put this in a context for nursing? Well, it all comes down to perfusion. Is your system able to deliver that good, like the goods, right? So if I have clots all throughout my arterial system, I'm screwed. I'm going to be in big trouble because it's not going to be able to get to where it needs to go in order to perfuse, to deliver that oxygen and those nutrients to the place that it needs to go, like my right big toe. Say I had some kind of surgical intervention, like a fem-pop bypass graft, and that is a femoral popliteal bypass. I am bypassing my femoral artery and trying to get past wherever there is dysfunction and involving your popliteal vein in order to get to pass that site. So when I worked in the surgical ICU full time, we had a ton of these vascular patients. And, you know, one of our top nursing assessments is to make sure that they have all their pulses posterior to where the surgical intervention was. You're going to have an issue past the surgical intervention. And what is that issue? Dead tissue, because you're not perfusing, right? So your pulses are super important for your cardiovascular system, cardiovascular assessment. Then the second one, removal of waste. So removal of waste. All right, well, this is not really a cardiovascular system that works in and of itself. You have to work with other systems in order to have your cardiovascular system do its function. In this case, removal of waste. So what other bodily system could you imagine would be involved with this? Respiratory, right? So what happens? We breathe out carbon dioxide. That entire system, from the very beginning to when you inhale down to exhale of the removal of the waste, involves the cardiovascular system. So in this case, number 2, removal of waste works in conjunction with your respiratory system. Then the next one is thermoregulation. Thermoregulation. Okay, so what I mean by thermoregulation is that your cardiovascular system, when there is an insult to the body, will try to compensate. It's trying to perfuse, it's trying to transport, it might be trying to clot or not clot, it might be fighting infection. Any kind of insult that occurs to your body, it is going to compensate. So often when the insult is big enough where your body is not able to compensate, we need to have medical interventions kind of step in. But one of the first actions that your body will do is clamp down. Clamp down, you'll hear clamp down, your patient's clamping down. That means your body is trying to perfuse only the most vital organs. All the rest, we can live without them for a couple of hours, even a couple of days. You might have a little bit of dysfunction after everything heals, but you know, your most vital organs obviously are the things that are most important. Those are the things that are going to keep you alive. Your heart, your respiratory system, and your brain. I have to have those in order to survive. So all the rest of your systems, you're not going to perfuse to it. And that's what it means by clamping down. It is only going to perfuse the most important systems. So I can live without my kidneys working for a little bit. I might not pee for a couple of days. I could live without having bowel sounds for a little while. Should that make you nervous? Yes. Yep, there are going to be lasting consequences, hopefully not too bad. But I'd rather have my brain, my heart, and my lungs being perfused. Then, you know, I could probably live without perfusing to my digits, my fingers, and my toes. Well, what's going to happen? They might turn blue, and if it happens too long, they could turn black and become necrotic. But your body is trying to maintain this balance, and that all happens from where you are going to deliver your blood, which is delivering oxygen and nutrients, right? Okay, so the next one, vasodilation, vasoconstriction. And then vasoconstriction. Oh boy, I'm running out of room. So vasodilation, vasoconstriction. There are times when your patient is going to need either more blood delivered to the site or less blood delivered to the site. Maybe your artery needs to be a smaller diameter or a bigger diameter, where you can deliver more of that blood at a higher quantity faster, right? So that's vasodilation, vasoconstriction. Your body can do that naturally as it tries to compensate, but we can also do it via pharmacology, and that's vasopressors. So I'm going to mess around with the mechanism of action, the drug that I want to give to the patient to either make them vasodilate or vasoconstrict. So here comes some of your previous learned knowledge from your other courses. It's definitely going to come back to haunt us in this class. How do I find that? Through assessment data is doing a blood pressure. Definitely grabbing a blood pressure. And I am not talking about an electronic blood pressure. Those things are calibrated like once a freaking year. You need to grab a manual blood pressure. And if they're really, really sick, then we will have an A line put in, an arterial line, where we can grab an arterial blood pressure, which is much more accurate than a manual blood pressure. Another thing that we can do is just see what the pulse feels like. Is it weak and thready? Is it bounding? Is it appropriate to the situation? So blood pressure and pulse are super important for vasodilation and vasoconstriction. Okay, here's another one. It is very similar to number one, but it's O2 transport. And what I mean by O2 transport is definitely perfusion. It is closely linked to delivering oxygen and nutrients, but what I'm talking about is the ability to actually transport the oxygen. So for some of our heme patients, this might be a little difficult. Hematologic patients. Do they have enough hematocrit and hemoglobin in order to actually aid in this oxygen transport? And that is part of the cardiovascular system. So how am I going to put this in terms of an assessment? Okay, if I am putting a pulse ox on my patient's finger, and I know that their H&H is low, don't be surprised if their SpO2 is in the toilet. That doesn't necessarily mean that that's what their actual oxygenation is. It just means that they're not transporting it to their finger, right? So what would be more appropriate? Grabbing an ABG, arterial blood gas, and accurately seeing what their oxygenation is doing, and grabbing an H&H and putting it all together. Maybe they need blood, and then they're going to be able to deliver the oxygen to where it needs to go through transport mechanisms. All right, the next one, clotting. Clotting. That is definitely a cardiovascular assessment. What I mean by that, we are always looking for DVTs. That would be in an extremity. Is it painful, swelling? Are there signs and symptoms comparable to having a clot in whatever extremity? If this was a PE, then you would probably see respiratory issues happen along with vital sign changes. Putting the whole situation together, did they have a DVT and now all of a sudden they're having respiratory issues? Could have broken off and went into a PE. How about our patients who have polycythemia vera? Those patients have super thick blood. They are going to have clotting issues. So sometimes they'll actually remove a lot of their blood in order to kind of make it more appropriate. So I think that's actually one of the topics that we talk about in this semester. So I kind of want to house polycythemia vera, but clotting is a huge one. We want to make sure that our patient is up and moving, they're breathing fine, they're doing active range of motion in order to prevent a clot. And then the last cardiovascular assessment function is to see about infection. So we want to see their ability to fight infection. So through their cardiovascular system, where it is perfusing, you might see heat, you might see swelling. In a complete blood cell count, you will see their white blood cells going up. That is all part of the cardiovascular system. So hopefully that put some emphasis and understanding upon our cardiovascular system. And then let's just talk briefly about some of the assessment things, the actual things that you are going to assess. Oh my goodness, I should have grabbed another one because now the purple is hanging out. A little bit later, I might have to stop this and just go get it wet again. Grab another one, but we'll see. All right, my friends. So your standard cardiovascular assessment things are going to be standard heart rate, blood pressure, all your vital signs, a temp, these are cardiovascular. Heart sounds. Do they have an S1, S2? They should Every patient should have an S1 and S2, but do they have an S3 or an S4? Clearly that's going to mean something else. Pulses, and then skin turgor. Okay, cardiovascular system. Now let's talk a little bit about, that's not like, this is just a quick 1-2, right? Now let's talk about specific things. What more specific can I look at when I'm doing a cardiovascular assessment? All right, well, how about the site surrounding a DVT? Am I able to feel that heat and swelling? Are they perfusing to the site? Does it look blue or red, right? How about JVD, jugular vein distension? Do they have a bruit and a thrill? And if they do, which they should, you shouldn't have jugular vein distension, but if you do, you should feel, and hear a bruit and a thrill. What does it feel like and what does it sound like? How about edema? I am not talking about edema like you have angioedema. I am talking about sclera. I've had patients where inside, right where their sclera is, it is so edematous, it's like one big sack of fluid. Do they have bilateral lower extremity edema? Do they have bilateral upper extremity edema? Are you talking about peripheral vascular disease or arterial disease? It will tell you the background to their cardiovascular system assessment. How about lung sounds? These are more specific. Crackles. Do you hear crackles, right? Crackles is fluid. Why is this cardiovascular important? All right, well, if you hear fluid, then they're having a hard time either keeping up with the fluid that they have or they have poor cardiac output. You follow me? How about chest pain or pressure? I hope immediately you're thinking about my song. Chest pain and pressure are very different. Chest pain is like you are being stabbed. Chest pressure is like an elephant sitting on your chest. And remember that men present very differently than women. So women through a heart attack might say, oh, I have lower back pain. All right. What woman do you know does not have lower back pain? We all have lower back pain. So a lot of women go undiagnosed for a while because they don't realize that they're having a heart attack. Here's another one, jaw pain. These are specific cardiovascular assessments. I talked about women. Okay, those are